multi-parametric MRI of the prostate.
Good morning, dear professors and colleagues. It's my pleasure to be here with you, and thanks for Professor Dr. Hani for the kind invitation. Today we will discuss the multiparametric MRI of the prostate. This is my acknowledgement, and this is the outline which we will talk about. Let's start why we should ask for a multiparametric MRI. It has multiple applications in prostate cancer evaluation, including detection, localization, and staging. Also, it is helpful in MRI-guided biopsy, in surveillance, focal therapy assessment, and also post-radiotherapy assessment, and in evaluation of biochemical recurrence. Let's start how to read MRI of the prostate. Read the prostate as three distinct zones. First, we have the central gland, which is located centrally over here. And then we can see that there is a peripheral zone which appears as a U-shaped appearance around the central gland. And also anteriorly, there is anterior fibromuscular stroma, and it appears as a dark T2 signal. The central gland, it has multiple components inside, and collectively it is called the transitional zone. It includes the periurethral gland, central zone, and the transitional zone collectively. And on the MRI, it appears as a central structure located within the center of the prostate, as highlighted over here. The peripheral zone, as we mentioned earlier, appears as a horseshoe appearance around the central gland, and this is the peripheral zone. The anterior fibromuscular stroma on T2, it is seen anteriorly, and it is thin and low signal on T2 weighted image. The peripheral zone is appearing as a hyperintensity, and at the apex of the prostate, it appears as a triangular shape, while in the mid part of the prostate gland, it appears as a horseshoe appearance, and in the base of the prostate, it is the smallest part of the peripheral zone surrounding the central gland with the adenomatous nodules. Adenomatous nodules developed only on the central gland. Let's see how to perform the multiparametric MRI. First of all, we should ask the patient if he had performed a biopsy recently or not. If he had a biopsy, the MRI should be postponed until the subsidence of the hemorrhagic content and the inflammation of the prostate is subsiding. And this is at least 6 weeks after the biopsy. As regards the preparation, there is no definite targeted preparation for the patient before doing the multiparametric MRI. Sometimes we can use the antispasmodic agent to allow the rectum not to be contracting during examination and induce artifact during the examination. And also we need to have serum creat and the PSA lab tests before the examination. The serum creat because we will inject contrast, and the PSA for the reporting and evaluating the PSA density. Let's ask a question: when to do the multiparametric MRI, on 1.5T or 3T? Actually, 3T is better for evaluation of the multiparametric MRI, and the guidelines recommend 3T imaging for the prostate. However, there are some indications where 1.5T could be of value, especially if the patient has a prosthesis in the hips, and this will hinder the image evaluation due to the artifact induced by the 3T image. And also, if the 3T is not available, 1.5T can be used, but with very limitation, because as we know that 3T has a better image resolution and better evaluation, and it is beneficial for prostate imaging by the guidelines compared to 1.5T. The multiparametric MRI included morphologic evaluation, which is the T2 weighted image in multiplanar, as we will mention shortly, and then we perform the functional imaging, including diffusion and ADC, and also the dynamic contrast enhanced images. The T2 weighted image is performed as a fast spin echo or turbo spin echo. The slice thickness should be small. It is about 3 millimeters. No gap is used to allow better evaluation of every portion of the prostate, and the imaging plan of the T2 should be implemented for the other sequences, including diffusion and DCE. And the field of view should be small field of view to allow better resolution for the prostate, either the central or the peripheral zone, and the maximum field is between 12 to 20 centimeter. The prostate axial T2 weighted image, it should be performed in oblique axial plane along the matching the long axis of the prostate. Let's see here, this is the sagittal T2 weighted image, and this is how we localize the axial planes for the prostate image to allow us to get this nice axial T2 weighted image with the central gland located over here and the peripheral zone, as we can see here in the mid prostate. For the coronal image, if it is added to the sequence, we can be satisfied with the axial T2 weighted image, but it's better to have another T2 weighted image, including the coronal image, and also the coronal image should be in oblique plane, matching the long axis of the prostate. As we can see here, this is the how we get the coronal image. And don't forget to include the seminal vesicles during the evaluation of the axial and coronal images in your field of view. The T2 appearance of prostate cancer to allow you to identify the lesions while you are performing the exam. This is the anteriorly located mass, and this is a peripheral mass located at the peripheral zone with associated extraprostatic extension, and this is a multifocal prostatic masses located at the peripheral zone. Let's move to the diffusion weighted image. It, as we know, it reflects the water molecule motions, and it is very essential in peripheral zone evaluation. We implemented the EDC map, which is needing to have 2 or more B values. Let's move at how we can adjust our B values. We should perform high B values for the prostate imaging, not the routine B values of 800 or 1000. We should have B values above 1,400, and this B value could be performed by 2 techniques. Either we instruct the machine to have these images initially by adding this B value to our imaging protocol, or we can use the routine diffusion weighted image, and then we calculate this high B value from the machine, and it is now available on most of the machines, the calculated B values, high B values from the implemented diffusion routinely. The diffusion weighted image is performed during free breathing, and again we should have a small field of view including the prostate and seminal vesicles to allow better resolution for the diffusion weighted image. And the axial planes should be as the same as the T2 weighted image in oblique axial planes parallel to the long axis of the prostate. And this is how the diffusion weighted image and its ADC for the prostate masses. Normally, we shouldn't see any restricted diffusion at the diffusion weighted image. This is a high B value, and this is a mass located at the peripheral zone with the restricted diffusion that was confirmed on the ADC map. Another example for a sizable mass located at the anterior prostate, including the central gland and anterior fibromuscular stroma, with the corresponding ADC map confirming this restricted diffusion. The T2 one-weighted image, it should be performed during imaging the prostate to allow us to evaluate any hemorrhagic content if the patient has a prior biopsy. And also it is very helpful in evaluation of lymph nodes and bone metastasis. As we can see here in this patient, we can see here the hemorrhagic components from previous biopsy, and also we can see the marrow infiltration at the right femoral head. The DCE, it is the acquisition of rapid T1 weighted images using gradient images, because it is a very rapid technique, and it is performed before, during, and all through during the IV contrast injection. The temporal resolution for this DCE should be less than 15 seconds per acquisition, and we could use fat suppression and subtracted images. It is recommended, but if it is not performed, we can do it later on with subtraction on the machine. 3D is better than 2D images, and now on the available machines, 3D is available on multiple machines. The slice thickness again should be small, and it is 3 millimeter, and the orientation should be the same as the T2 and the diffusion weighted image. The field of view should include the seminal vesicles, and we perform this DCE for more than 2 minutes. From 2 to 5 minutes is adequate for performing the DCE. This is the DCE showing the mass showing having a hyper enhancement during the DCE, and this is the color map performed for this DCE. Let's move to just to notice about the biparametric MRI. It is now sometimes used if the patient have a contraindication for using IV contrast injection. It is the same as multiparametric, but just we omit the DCE component. And finally, we implement all the acquisition data by RADS scoring version V21, and we get our final report for evaluation of the prostate. Thank you.
Thank you, Dr. Rasha, for this wonderful lecture. We will invite Dr.